Good morning or good afternoon, depending on where you're joining us from today. I want to start by saying welcome and thank you for joining us for today's webinar. Today, we will be discussing medication-assisted treatment, really with the focus on trends and outcomes. With that being said, just a couple of things I'd like to highlight. We definitely want to hear from all of you, encourage participation, questions, comments. Please utilize the chat for any of that. Ryan and I will do our best at the end to get through as many of those questions as possible. I also did want to let you all know that we're going to have several poll questions throughout today's session and encourage your participation in those as well. So if we go to the next slide, I did want to start by introducing myself, and then I'll let Ryan introduce himself as well. My name is Megan Garrity, Director of Operations for Genoa. I have been a practicing pharmacist for 12 years, primarily in the community setting, and recently joining the Genoa family, coming up on almost 2 years. As a Director of Operations at Genoa, oversee anything pharmacy related within the state of Massachusetts, Connecticut, and Rhode Island. I do reside in the state of Massachusetts, but originally from Maine. So if there are any Mainers on today's call, with my 2 young sons. So I'm very excited to be talking about this relevant topic with all of you today. So Ryan, if you want to introduce yourself.
Thanks, Megan. Good afternoon, everyone. I am Ryan Grant. I am a pharmacist and manager of pharmacy operations for Genoa Healthcare at our Waterford, Michigan location. We are located within CNS Healthcare. So shout out to my CNS peeps that are on the call. CNS is a community mental health center that serves Southeast Michigan. And why that's relevant is because CNS operates a robust and successful MAT program that heavily involves the pharmacy team. So we're going to talk about some of those pieces a little bit later on. A little bit more about me. I've been a practicing pharmacist for 7 years. I spent the majority of my career also in the community setting prior to coming to Genoa. I live in Southeast Michigan with my partner, James. And like Megan said, very excited to be with you today, talk about this very important topic. We really want to start with our why and end with our why. And the why is our consumers, our patients, our clients. In a few moments, Megan will start to tell you a little bit more about the need that is out there in the MAT space. She'll tell you a little bit about some of the tools that are available at our disposal in medications that are approved for this condition. And then we'll also talk about some of the people. And it's those of you that are on the call with us today, people that are involved that make the magic happen, caring for these consumers. So that really is where we want to begin and end with the Genoa consumer success story a little bit later on. But keep 3 words in mind as we progress. Recovery is possible. So I want you to keep that in mind, and we're very honored to be a part of this discussion with you today. So with that, Megan, I'll let you kick us off.
Yeah, thanks, Ryan. So we did want to start just by setting the landscape here a little bit and really giving some defining terms around medication-assisted treatment, if that's new to you. But really, it's the use of medication in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. Medications used in MAT are approved by the FDA, the Food and Drug Administration, and MAT programs are clinically driven and tailored to meet each patient's specific needs. Medication-assisted treatment is a term used to describe the use of medication along with other support to treat opioid, tobacco, or alcohol use disorder. Although the term and method are not new, MAT has recently gained renewed attention as a key to combating opioid use disorder, which is a chronic health condition that can be life-threatening, but also treatable. Under federal law, MAT patients receiving treatment in OTPs must receive counseling, which may include different forms of behavioral health. These services are required along with medical, vocational, educational, and other assessment and treatment services. The opioid epidemic is widespread and impacts, individuals and communities as a whole. If you look at some of these statistics shared on the screen here, 1 in 8 children aged 17 or younger live in a household with at least one parent who had a substance use disorder. And, tragically, only 20% of individuals with OUD get the treatment that they need. And again, kind of setting the landscape, currently in the United States, about 1.27 million Americans are now receiving MAT treatment. We go to the next slide. On March 11th, 2022, the World Health Organization announced the COVID-19 outbreak can be characterized as a pandemic. This is highlighted on the graph shown on your screen by the red arrow. U.S. drug overdose deaths began accelerating during this time. The acceleration of overdose deaths corresponded with implementation of the national stay-at-home order as part of the 15 days to slow the spread initiative, and also the rise in COVID-19 cases. When you think about the impact that the pandemic had on all of us, very socially isolating, tremendous mental health impacts, job loss, financial strain, missed touch points and opportunities for intervention, canceled or postponed medical care, right, due to COVID-19 fear, diagnosis, clinic restrictions, lots of impact here. Multiple reports have indicated that overdose have increased during the COVID-19 pandemic. And in December 2020, the Center for Disease Control and Prevention issued a health advisory highlighting provisional data indicating a substantial increase in overdose deaths beginning in 2019 and really accelerating in early 2020. A call for essential services to remain accessible for those at risk.
It's crazy, Megan. I mean, to stop and take a moment and look at the impact. I mean, here we are almost 3 years later, soon to be 3 years later, and certainly a very negative impact on that community that all of us have felt in a different way.
Yeah, yes. Thank you, Ryan. All right, if we move to the next slide. So this is our first poll question. Very much encourage you guys to contribute here. But do you notice any type of gap or in Narcan education with consumers and or staff at your clinic? So encourage participation here, and we'll give you guys a minute to respond. All right, so it looks like the most popular answer, 70% are saying yes, there's a gap. I think what I really wanted to highlight here, most states allow for access to Narcan without a prescription, right, through a standing order. And again, there is variability out there state to state, but lots of options there to really get this product in the hands of individuals and families that need it. So if you have questions there and you have a general pharmacist, please feel free to connect with them. I think we could provide a lot of support there. All right, next slide.
Hey, Megan, good question came in the chat too. One of the guests wanted to know, was the webinar being recorded? Would it be shared later? So yes, it will.
Yes, absolutely. You guys will all get an emailed copy as well. So thank you for that. All right, so we talked a little bit about, what is MAT, talked about obviously that trend that we've seen through the pandemic, right? And then this really just talks about overarching goals of an MAT program set really by SAMHSA, right? So number one is to improve patient survival. Two would be increase retention and treatment, decrease opiate use among people with substance use disorder, increase their ability to gain employment, and then improve birth outcomes among women who have SUDs and are pregnant. So when you think about MAT, the ultimate goal is full recovery, right? Including the ability to live a self-directed life and these 5 components on the screen. So just kind of want to set some goals here. So we go to the next slide. All right, I'm going to highlight some medication treatment options. There really are 3 drugs approved by the FDA for the treatment of opioid dependence. Those would be buprenorphine, methadone, and naltrexone. All 3 of these treatments have been demonstrated to be safe and effective in combination, obviously, with the counseling and the psychosocial support that we talked about earlier. Everyone who seeks treatment for an OUD should have been offered access to all of these options, as this will allow the providers to work with patients to select the treatment best suited to that individual's needs. Due to the chronic nature of OUD, the need for continuing MAT should be reevaluated periodically. There is no maximum or minimum recommended duration of maintenance treatment, and for some patients, treatments will continue indefinitely. So if you go to the next slide, I'm going to highlight some of the products here, and there's a lot of detail on here, but just wanted to at least give some insight. And so these are all FDA approved products on the market for MAT currently. So when you think about buprenorphine products, they can be prescribed by a qualified physician, physician assistant, or nurse practitioner OTPs or office-based practices per federal regulations. Buprenorphine is available in a bunch of different formulations. So a sublingual, which is under the tongue, buccal, which is in the cheek, an extended release injectable form that we'll talk about a little bit later, and as well as an implant formulation. So lots of options there. Naltrexone, similarly, can be prescribed by physicians, physician assistants, and nurse practitioners who are licensed to prescribe medications. Naltrexone is available in oral and extended release injectable formulations. The extended release injectable formulation has shown some better adherence rate compared to oral tablets as well. All right, next slide. And it continued, some FDA-approved products here that we just wanted to highlight. As you saw from the prior slide, MAT drugs can be administered through a lot of different routes depending on the specific drug. When you think about methadone in particular, it's usually orally administered through an OTP, right, an opioid treatment program that must be certified by both SAMHSA and the DEA, registered with the DEA. Generally, a patient taking methadone would visit a clinic every day to take the medicine under appropriate supervision. However, back to that March 16th, 2020 date, SAMHSA did issue an exemption to opioid treatment programs where a state could request a blanket exception for all stable patients in an OTP to receive 28 days of take-home doses for patients who are considered stable. States then also could request up to 14 days of take-home medication for patients who are maybe less stable, but the OTP felt they can safely handle the medication at home independently. Almost 2 years since this exemption was granted, states, OTPs, and other stakeholders report that it's resulted in a tremendous increase in treatment engagement, improved patient satisfaction with care, and very few incidents of misuse or medication diversion. There is sufficient evidence to conclude this exemption has enhanced and encouraged use of OTP services. SAMHSA recently talked about considering mechanisms to make this flexibility permanent. All right, next slide. So just to pause here for a second, we've talked again about, what is MAT, why, right? This need within the country that in, the patients that we take care of, and a little bit about, some of the medications there that are approved for MAT programs. I did want to kind of bring that all back, and we're going to highlight, this is one example. There's many out there about how an MAT program has really impacted significantly folks with OUD. So this was a study, there's some statistics here, but I'm going to talk through a lot of it, that was published by the NIH. It was a chart review of 472 patients in a very rural community receiving MAT treatment through telemedicine. The study really aimed to examine demographic and substance use variables for individuals who consented to telemedicine treatment, retention and treatment over time, and opioid use over time to understand the impact of prescribing buprenorphine and naltrexone via telemedicine to patients in a rural setting with OUD. The findings ultimately supported the effectiveness of, MAT, and then also the telemedicine component as well. So the statistics on your screen, 81% of buprenorphine prescribed patients were opioid negative at baseline or the day of treatment initiation. 41% of those individuals were engaged in treatment by the end of the third month of treatment. However, their toxicology screens were almost 100% negative. So meaning that the impact that MAT had on these particular individuals was very successful. So just like to kind of highlight an example there, right, of how this can kind of all come together and help all those individuals that we serve. All right. So I'm going to take a little pause here and switch it over to Ryan. He's got some of the fun and exciting new stuff that's going on. So Ryan, I'll turn it over to you.
Thanks, Megan. Thanks a lot. Thanks for painting the picture for us, really letting us understand, get a sense of how big is the issue. There's certainly need. We saw that with the graph depicted at the beginning. Again, we have the tools available in the safe and effective medications that are approved in the MAT space. So like Megan said, I'm going to talk about what's to come, what's in the pipeline from an emerging trends perspective. But before we do that, I did want to stop and recognize the group. We have a very large group on today. That's a testament to your commitment to caring for the people that we serve, that you serve. So very grateful again to be a part of this. And I think this is a very relevant topic that's been heavily attended, obviously, today. So we're going to talk about some emerging trends in the MAT space, and we're going to do that in the regards of four emerging trends. The first being regulations and regulatory changes in the MAT space. We're going to talk a little bit about mobile care in something that I like to refer to as the ecosystem of care. That's kind of like the gold standard that we're shooting for here, to create this ecosystem of care where our consumers have frequent touch points with multiple individuals, be them nurses, prescribers, pharmacists, as you'll find out, other individuals as well. Then we're going to talk about an app that is available to assist prescribers entering the MAT space. And then finally, we will touch on an injectable treatment option. And Megan didn't steal my thunder. She didn't give you the name of that, verbally at least. It was on the slide, so I'm curious to hear. We will discuss an injectable treatment option, injectable extended release buprenorphine product that is available. And I'm curious if anybody can help us blow that chat up. Let me know what product we might be referring to, and we'll see if you're right in a few slides. But this product is gaining market share. They're already coming in, Megan, with the correct answer. So that is it. Sublocade, we'll get to that. So thanks for the participation there. So next slide, please, Nick. So the first trend we're going to talk about is in the regulatory space. So in January of last year, the U.S. Department of Health and Human Services issued updated practice guidelines for the use of buprenorphine to treat opioid use disorder. And so when these to increase access to these very important medications for those that need the medications. When the guidelines were introduced, though, it did create a myth amongst some individuals in the community that X waivers would no longer be required. And it is a myth. I'm here to dispel that for you. X waivers are indeed still required. What this did, though, was simplify or streamline the process for prescribers, maybe that hadn't considered entering the MAT space before or didn't have much experience with MAT. It allowed them to seek certification by removing some of those certification requirements to obtain an X waiver from SAMHSA, the Substance Abuse and Mental Health Services Administration. And so those prescribers that seek certification through this route are limited to caring for 30 patients at any one time. So again, regulations were introduced in January of 21, and they did accomplish the intent of increasing access and availability of these MAT medications, but X waivers are indeed still required to prescribe the medications we discussed earlier. Go ahead to the next slide, Nick. Okay, so now we're going to talk about a study that was conducted in Maryland, in an underserved community in Maryland. And I know many of our clinics, many of our general pharmacies are located in underserved communities. So I think the data does definitely, it is relevant to what we're discussing here today. So these researchers in Maryland, what did they do? They referred to this telemedicine mobile treatment unit. That's something that they used as part of the study. In Michigan, we keep it real. It is an RV. Basically, they established an RV that was staffed by a nurse, a peer recovery specialist, and a substance use counselor. So there was no prescriber in this mobile unit in the RV. The prescribers were remote, seeing these individuals remote. There's the telemedicine component. And essentially, the consumers would visit with the staff in the RV, take their vitals, do the baseline monitoring, et cetera. And then the prescriber would issue the buprenorphine prescription for the consumer to pick up at their own independent, local pharmacy. And what they did, they measured consumer success and retention engagement at baseline, 30 days, and 60 days into treatment. And what they found was that those individuals that were being served via this telemedicine mobile treatment unit had just as good of outcomes. The results were non-inferior to the group of consumers treated in person with the physician. So what does that mean for us? Obviously, we would like to have all the individuals that need MAT services available or have that at their disposal, but we know that's not possible. Many of the individuals that we serve have transportation barriers, that sort of thing. And so leveraging telemedicine where appropriate, you shouldn't be concerned that individuals will have worse outcomes from that component. Go ahead to the next slide, Nick. So as we continue on the conversation on the technology piece, this is the app that I was telling you about. There was an app that was published by researchers at BMC, Boston Medical Center. They created an app. It is available today. I have it on my phone, even though I'm not a prescriber. And what this does, I think it's really nice. It's a tool that's maybe most helpful for prescribers that are new to the MAT space, looking for some of that clinical guidance. And that's what the app provides. Obviously, practicing medicine and treating consumers in the MAT space is a science and an art. And so you can't strictly read guidelines and know how you're going to treat all of your consumers, but the app could help certainly new prescribers that are looking to enter this space, provide them with up-to-date clinical decision-making information from guidelines that are well-published and studied. Like I said, most useful perhaps for those prescribers that are new to this space.
Yeah, Ryan, I know we've talked about this before, but you think about really expanding the reach of MAT, right? And getting it in, these tools in the hands of more prescribers. Just really cool. Nice to see, right? Technology coming into play here. So, and then Ryan, I did just have one quick question while we're on this topic that came in the chat. I thought we could pause for this study for the last one that you were talking about with the RV. That was in Maryland, correct?
Correct.
I was asking. Yeah. Okay. And then who were the individuals included in that team?
There was in the treatment team.
Yes. Yep.
So this particular study did not incorporate a pharmacist. We will get to that different study in that space a little bit later on. But there was a nurse as part of the unit. There was a peer recovery specialist staffed on the RV, and then the prescribers were remote. Okay.
Good. And then just to tag on that, so a question came in about examples of studies with telemedicine. So that really was, right, the prescriber was telemed in that case. And then the study that I shared earlier, the smaller chart review, that was also telemedicine as well. So yes, lots of examples of, making this work in today's environment.
Awesome. Yeah. And the impact of COVID. I mean, I know I can speak for my clinic. We still serve a lot of our consumers remotely. And that was not the case prior to the, January or March of 2020. So we've had to change how we care for those individuals. All right, Nick, go ahead to the next slide. So another emerging trend we talked about a little bit earlier is an injectable treatment option for our consumers in the MAT space in Sublocade. So Sublocade is injectable extended release buprenorphine. It was officially launched in 2017, so it's not brand new. So I hope many of you have heard of it before. Evidenced by the chat, you have. It is approved for use as maintenance treatment of moderate to severe OUD in patients that have first initiated the transmucosal buprenorphine to start. So that they have to be on that product for 7 days to know that they're a good candidate for buprenorphine. And data from the Urban Institute is telling us that Sublocade is gaining market share. Really, there are some benefits to this product for our consumers. It's great from an adherence perspective. It doesn't involve daily dosing. As an injectable, it's a once monthly injection. And so it delivers a continuous release of medication all throughout the month. So you also don't have to worry about, from an adherence standpoint, the consumer missing doses, but then also the highs and lows of dosing throughout the day with many of the other products. So it is, like I said, it's gaining market share. One of the barriers that's holding Sublocade back, from speaking with some of the colleagues at that company, is state coverage of the products vary state to state. So state Medicaid coverage of this particular product is not uniform across the board. We are fortunate in the state of Michigan that it is an approved product for Medicaid recipients. But I think as we continue to move forward, we will see perhaps greater use and utilization of Sublocade in this space because of the benefits that I mentioned to you. Anything to add on that one, Megan?
No, I think you got a lot of it, Ryan. Thank you.
Okay. Yeah. So this does take us into one of our next poll questions. If you can advance to that for us, Nick. So we'd like to hear from you. Does your clinic currently offer Sublocade as a treatment option for patients? Let us know yes, no, that you don't know enough about it yet, or no, it's not needed at my clinic. while we're waiting for the guest to answer that question, there was a good question that came in about pharmacists being able to administer Sublocade. And that'd be great. I mean, I've worked with our compliance team to perhaps pursue that, but it isn't allowed per REMS regulations at this time. So hopefully something where we could see the pharmacist leverage to do that in the future. So our results to the poll question, the winner is no, I don't know enough about it. So maybe a little bit surprising, maybe not for some. 55% telling us that they don't know enough about it. So great opportunity to provide education there. All right, Nick, go ahead. Let's move us to the next slide. So as a pharmacist, this one is near and dear to my heart. We're going to look at a study in the Appalachian region of the Eastern United States involving a pharmacist or incorporating a pharmacist into an interdisciplinary MAT program. And I really like how this study framed the use of the pharmacist. They said that the pharmacist was leveraged as an extender. The intention was not to duplicate or compete with the role of the physician, but as an added member of the MAT treatment program. So it was a qualitative study put on by East Tennessee State University's College of Pharmacy. Like I said, a pharmacist was integrated into the care team. This particular pharmacist had extensive training in the MAT space. They were a board certified psychiatric pharmacist. And you might ask yourself, why was the study, was it conducted in that particular region of the country? And that Appalachian region of the Eastern United States has been particularly heavily impacted by the opioid epidemic. Some of you may be joining us from that area, would know firsthand, but there's a statistic that I think is pretty eye-opening or mind-boggling to me. Over a 6-year period, from 2006 to 2012, a single community in the state of Virginia was shipped more than 8 million dosages of opioid medication in that time frame. So it is a small community, Norton, Virginia, and that translates, when you look at the number of residents in that community, to 306 tablets of an opioid medication per resident per year. So very eye-opening. I mean, the amount of opioids that were being distributed to this particular region of the country. And as such, the graph or the map that's on your screen now translates into a very heavy use and utilization of buprenorphine products. So you can see there the dark colored counties highlighted on the map have a very high use of buprenorphine, which is a positive I would take away from this data, that these individuals now are perhaps pursuing MAT treatment, trying to change their addiction or that situation that they're in with the opioids. So, like I said, a qualitative study that was conducted where the pharmacist was involved in the MAT treatment program. What did they do? Some of the roles of the pharmacist are listed on the screen, where the pharmacist was able to provide education to the clients about buprenorphine, assisted with identifying the correct dose for the consumer, also participating in group. So the pharmacist, like I said, was a member of that MAT program and was leveraged in group. And then finally, as Megan touched on earlier, the role that the pharmacist can really play comes into play with Narcan. And in this particular study, Narcan education was a requirement of each client in the MAT program. And so the pharmacist was leveraged for that component as well. What were the outcomes? Was there an impact? And there was. The authors of the study published that buprenorphine medication adherence increased, leveraging the pharmacist as part of their team. There was also decreased diversion of buprenorphine, another positive. And then overdoses were prevented as part of the naloxone training component of this program. So a really nice example that highlights different roles that pharmacists can play in this space to assist with caring for these consumers. As we shift gears a little bit, we want to hear from you. We'd like to have these webinars throughout the year, and we'd love to get your feedback. What are some of the topics that you would like to be discussed as we turn the page into the new calendar year? We're 17 days away from 2023.
Doesn't feel real.
Have you done all your Christmas shopping yet, Megan?
No.
I have not either. No. But we'd love to get your feedback. Drop that in the chat. Let us know so that the team at Genoa can start planning for some topics to cover in the new year. So with that, please share your feedback. I'd like to turn it back over to Megan and we'll start some Q&A.
Yes. All right. Lots of questions, and I was trying to organize them a little bit, Ryan, as you were talking there. But so we're going to go into our Q&A session. If we don't get to you, or quite frankly, if we don't have a thoughtful answer for you, we will make sure that we circle back and provide that information as well. But Ryan and I did want to share our contact information here. So these are our email addresses. Any feedback, questions, things that we can help with, please leverage us. We're here to help. All right, so I'm going to go way back, and I'll take this one, Ryan, because this one's about Narcan. But we were talking about that poll question, right? And really kind of having an understanding of how pharmacy, how Genoa can potentially help here. The question is, did Genoa offer a free Narcan without a prescription? So the answer to that is no. We do, like I said, in most states have the ability to bill a Narcan prescription to an individual's insurance without that barrier of a prescription, right? So most states allow for some form of that. Again, very state specific. There are often co-pays attached to those products. Just to call out, in states that have that, that standing order set up where we don't need a prescription, anyone can walk in. They can get one for themselves. They can get one for maybe a family member. They want to have one maybe because of their role in the community. So lots of options there from a Narcan standpoint. So, all right.
Megan, there was a good question that came in about the REMS program. So good call out. Sublocade question was, what is the reason really that a Sublocade is part of a REMS program? We should mention that Sublocade is part of a REMS program for safety. And as part of that REMS program, there are certain requirements. Like I said, only certain pharmacies can actually dispense Sublocade. Not all pharmacies are certified to provide that medication. And in order for the pharmacy to dispense Sublocade, it can only be provided to the office. It is obviously not a product that can be dispensed to an individual consumer themselves. So it is dispensed directly to the office, and it can only be shipped to the prescriber's DEA registered address. So that is another component of the REMS program for Sublocade. So if I order Sublocade for a consumer, the only location that can receive the product is the DEA registered address on file for that prescriber. So good question there. What are the reasons for the REMS program for Sublocade? And obviously it cannot be dispensed to the individual consumer. There are other aspects as well that have to be maintained as part of the REMS program.
Yeah. And just to piggyback on that, Ryan, REMS in general, right, is meant to keep everyone safe, right? So that the medication ends up in appropriate hands, right? Folks that are, equipped and trained to handle that type of medication. So there was a question, and I'll take this one, Ryan. Let me see if I can get back to it. It was about, it says the 30 patient limit, is that still for just an initial time period, or did they change it? I think this is about just patient count, right? So after a year, you can apply to see up to 100 patients per SAMHSA regulation. So I think that was the answer to that one. So, all right, let's see. Ryan, for the mobile unit study, did you know if the participants were part of any like outpatient recovery meeting or group?
As like part of an ongoing treatment.
Yeah, to be able to participate in the telemedicine component of it. Do you know?
Yes. So I know that there were, frequent visits, like the RV would come to them. The prescriber was remote, like we said. And as part of that visit, they would participate in group, that sort of thing.
Okay. Let's see. This talks a little bit about Suboxone to Sublocade. I know they have to at least have some oral history there. Is it 7 days, Ryan?
Correct. Mm-hmm.
Okay. So do you want to just elaborate that on a little bit more?
As an injectable option, obviously we don't want to inject a consumer with injectable buprenorphine if we know that they can't tolerate it, or we want to make sure that they can tolerate it before we were to provide that long-acting medication. It is a once monthly injection. So the duration of action of that product would last the full month and you wouldn't want to provide that to someone who could potentially have an adverse reaction for that period of time. There was a question also on that same space around administration. It's a subcutaneous administration route, Sublocade. So important that it is not intramuscular. And as part of the REMS program, there are requirements around certain stickers and information that has to be provided with the product for correct administration. So it is subcutaneous. It's not to be administered IV or intramuscularly. And there are specific warnings and labels that come with the product to make sure that the staff that's handling that knows that first and foremost.
Yeah, great. There's another question that just came in talking about, I noticed SAMHSA recommends a medical exam before prescribing Suboxone. How important? So I wouldn't say we're necessarily experts on this piece, but I will, as a pharmacist, comment when you think about the OUD population, right? Or any type of substance use, really, there's often other comorbidities involved there, right? Other health concerns that are happening. And anytime you're starting someone on a new drug therapy, right? Some of these drugs that we talked about have contraindications, right? The various warnings. As a pharmacist, I think it would be good to have a baseline, right? Where is that individual at from an overall health standpoint? Any hepatic, renal concerns, history of allergies, right? So for me, I think that's why SAMHSA has that recommendation there, I would assume, right? But just wanted to comment on that question. So
there was a question, Megan, about local pharmacies not filling prescriptions for Suboxone or not stocking that product, and asking about Genoa locations. Do we carry Suboxone? So many of our Genoa pharmacies are co-located within behavioral health centers or substance addiction treatment centers. And so as long as there is demand for that product, the pharmacy has access to order that. And I think that is something that I do hear from my colleagues in the community space. There's a misconception, sometimes around consumers that receive Suboxone as these individuals are, drug seeking or that sort of thing. But we should look at Suboxone treatment, MAT treatment, as really someone's lifeline. They're trying to better themselves. They're trying to make the right decisions to get off street drugs or opioids. So that extra scrutiny that sometimes happens in the community setting. With our specialized training, the technicians and pharmacists at Genoa undergo, mental health first aid, have more knowledge of this space than traditionally, pharmacists in the community setting. And so that is a unique advantage that we're able to offer.
Great. Thank you, Ryan. Jumping around here a little bit, another question came in about Narcan, about the cost. So we do have the ability, rather than dispensing as an individual prescription, to sell that product to our clinic partners. So I would just suggest following up with your Genoa pharmacy, and we can further discuss that if that's a need. So,
and I know on that note, Megan, too, our clinic has requested samples of Narcan. So Genoa pharmacies can provide, as long as it's allowed by state regulations, can provide clinics with floor stock of medications. So if a clinic wanted to purchase, Narcan to have on hand at the clinic, or for their staff to have available, or even for consumers to have as well, that is something that Genoa pharmacies can do.
See.
Lots of participation in the questions, lots of good questions that came in.
There's one about here. What are your thoughts on the prescription Adderall? I'm assuming that's just the scarcity, availability. Ryan, do you have any more insight on that question? Do you want to take that one?
Sure. Yeah, I know from firsthand experience, we are struggling with maintaining in-stock status of Adderall. Really, all of the generic amphetamines, the name brand products are in short supply right now. So I think, speaking with the consumers about alternatives, and everybody's, if they're on a 20 milligram, a lot of them are trying to take 2 of the 10s. And so now the 10s are out of stock. So certainly that's a conversation to have with your Genoa pharmacist. Let us search our supplier's website, get that most up-to-date information on inventory so that you can prescribe what is available right now.
Great. There's one question in here, and I'll just make a suggestion, talking about Sublocade. We don't offer it at our clinic because we don't know how to get it covered, which I know, Ryan, you quickly talked about some of those coverage challenges. Again, would encourage you to work with your Genoa pharmacy if you're currently co-located with one. We do have a small ability to medically bill some prescriptions, versus just the pharmacy benefit. So if you haven't partnered with your pharmacy, I would just encourage you to do that, to see if we can help out in that capacity. So
absolutely.
This is a good one, because I know this comes up a lot. Can multiple addresses be on file for one particular prescriber? And I'm assuming this is in relation to Sublocade. So in this particular case, you would have to get another DEA license with that correct address on there. So yes, you can have a DEA license with multiple licenses listed. Anything you want to add on that, Ryan, if you have any more insight there?
I would say that from a monitoring perspective, there are safety nets in place where the company looks at, like, if a prescriber has multiple addresses, they see patients out of multiple locations. There's a lot of things that happen behind the scenes to ensure that our pharmacy teams get that medication only to the DEA registered address. So like Megan said, you can practice out of multiple locations, obviously, but it would require a DEA registered address to be specific to that site to receive the medication from the pharmacy.
Yep.
Sublocade is very costly. That was a question about, it's a very costly treatment option. And so, like I said earlier, not all pharmacies are able to provide this medication. So it is a great opportunity to leverage your Genoa pharmacist and pharmacy team to get that in when you need it, because of the high cost of the product. It's not something that you can order from, a traditional retail pharmacy to have that filled.
Yeah. Another question here on a clinic that's starting an MAT program. From the start, when and where how do we get pharmacy involved, right? And, as in my role at Genoa, I would say the sooner the better, right? So that we have obviously the medications, thinking about hours, right? When are these folks going to be coming in and needing to see our pharmacists and see our pharmacy team? Just making sure we have the resources available, right? Even back to Narcan and talking about, I have a couple MAT programs in Massachusetts where everyone leaves with a Narcan in hand, right? When they leave the program. So just something to think about. I would say the earlier the better when you're thinking about how to partner with your Genoa pharmacy.
There was a question about, how do I start an MAT program? Where to start? When to get the pharmacy involved? So certainly there are tons of resources available on SAMHSA's website to support prescribers that are interested in becoming MAT prescribers. And then the app, I would encourage you to check that BMC app out as well. Take a look and see what advice, it may seem daunting to establish an MAT treatment program at your clinic, but it really is, there's a huge need and it's not as complicated as it may seem.
Yeah. Our clients bill directly for Sublocade. So yes, we would bill their individual insurance for that. Anything else, Ryan? There's some coming in through the Q&A and then some through the chat. So I'm just trying to balance it all.
Appreciate the participation very much. Let's take a look.
Yeah, someone actually, I was going to mention this earlier. Someone commented on Narcan being available locally, the health department, the courthouse, free vending machines stocked with it, which is, I've never seen that, super innovative. But yeah, lots of, typically there's lots of grant options out there. I know that's how at least a lot of our partners, obtain like the floor stock capacity of it, right? How do I have it in my clinic available to my team? And I've seen it in that capacity. So thank you for that comment.
I'd say too, to go back to the question where the prescriber was considering getting into the MAT space, ask around. Someone mentioned in the chat that they have administered over 3,000 Sublocade injections. So there are people that are doing this where you are, I'm sure. Ask your colleagues, speak with the pharmacist. Just because you may not be getting Sublocade from your general pharmacy, the pharmacy may be providing that to another office where they could connect you with and share best practices, et cetera.
Yeah. Another Narcan question: how to educate teams on administering Narcan. I'll tell you, back to the market that I'm in, we've had general pharmacists go out and do trainings for staff. We've done trainings in the community at community events. So definitely leverage that pharmacy team if you have one there with you. So happy to help in that capacity. That's what we're here for. So.
Question about best practices for involving the general pharmacist as part of the mental health care team. Great question. That's music to our ears. Certainly communication. It starts with communication, getting to know that pharmacist, the pharmacy team on a personal level. Let us know. We want to come to you at the time. Everyone has very busy schedules, of course. We want to connect with you when you're available to make sure that you're aware of all the services that we can provide, how we can help you. Basically, if you come to us and let us know, this would really help at my clinic. It would be particularly helpful for you to provide Narcan to the consumers that I see as part of MAT. Or I want my consumers to receive their medication in specialized packaging. Whatever you need for your consumers, let us figure out how we can accomplish that. But we'd love the opportunity to do that.
Yeah. And just to piggyback on what Ryan said there, how to really integrate there. And we so much appreciate that question, but attend staff meetings, right? We're happy to do lunch and learns. I know in Massachusetts in particular, we've done some lunch and learns around Narcan training, right? And how do we get more people educated and aware of what our process is to get that out into the community? So any of those events that you have kind of happening normally within your clinic and you want your pharmacy team to be there, we're happy to collaborate in that way.
There was another question, Megan, about some of the links to the studies. So absolutely, when we send out this information, we'll give you the citation for the studies that we mentioned today. They said they'd like to share it with some of their pharmacist friends.
I saw that one. Yes, that's a good one. All right. I don't see a lot more coming in. Unless, Ryan, you want to give it one more look?
Yeah, I guess this was maybe a potential future topic for us. So shifting from oral antipsychotics to LAIs, or from one LAI to another. So long-acting injectable medications. Maybe that's a future topic for us to consider. Thanks for the idea on that one.
Yeah, here's a couple more just came in talking about the clinic I work at has a general pharmacy, but we don't order our Sublocade injections from them. We have to get them in bulk from a specialty pharmacy or supplier. Do you know why? If you know your director of operations, that'd be a great question, or your site manager, and get their information. Not sure, obviously, of the details there, if it has to do with a contract or whatever it may be, but director of operations or site manager would be a really good follow-up on that one.
Another one that came in, Megan, around insurance companies covering MAT. That's definitely a good question for your general pharmacist, so that they can look into, does your state, we're fortunate in the state of Michigan to have a common formulary where all of the community plans adopted the same formulary that's available to the public, to professionals. So in some states that may be available, where you could almost, print out that guide of what's covered under the Medicaid formulary, or speak with the pharmacist. If you have a consumer that you want to have this medication, let us test it, if their insurance covers it or not, get you that information so that they're not surprised by costs.
Yeah. Another one, can you do a lunch and learn on dosing protocols for Suboxone? Absolutely. And then have a comment here, kind of miscellaneous questions about how to increase client load. A lot of those resources are already available on the SAMHSA website. So I think, Ryan, you might have said that a little bit earlier about in reference to something else. That's a great resource for some of these questions as well. All right. Well, I think the chat has started to slow down. If, like I said, we were kind of balancing two pieces there. So if we missed you, please reach out. I did notice in this deck on this slide right here that we're looking at, my email address is mgarrity. There's two R's, so MGARRITY. Ryan, your email address, I believe, looks correct there.
Yes.
Please reach out to us. You will be getting, like we said, a recorded copy of this as well. And I know there are at least a couple questions in the chat that Ryan and I will do a little bit more digging on and get back to you guys with answers on those. So
Appreciate the engagement very much.
yes, very exciting. So I think with that, we will wrap, and we just want to say thank you so much to, I mean, we've said it a couple of times, but just really appreciate the engagement and all of you thinking so thoughtfully about your collaboration with your Genoa pharmacy too. So if you guys need anything at all, questions, comments, please reach out to us. We're here to help. So thank you all for attending. Happy holidays, and hopefully we see you next quarter.
Happy New Year.